the point is that ESO never had done a guideline about PFO. There was a Karolinska consensus written about the indication of closing or not closing the PFO. And it was not done by this rigorous grade system. So we needed a really updated meta-analysis, as a lot of new, not really new trials, but more knowledge. And we needed a really rigorous approach to this, because it's a rare disease. But when it happened, a clinician need a clear guidance when and how to close or how to treat the PFO. We divided the guidelines in 3 parts. One was diagnosis, second was treatment, and long-term management. So regarding diagnosis, what we found that, based on the rigorous grade system approach, we could not give a definite indication which diagnostic tool has to be used. There are some observational studies about transcranial Doppler, about transesophageal and transthoracic echography, but there's no gold standard. Even if we all think that transesophageal echography is the gold standard, it's not like this, because there have never been a study to validate transesophageal echography as gold standard. So we tried to, we compared all the methodologies, but in the end, there was no clear indication. So we did a very pragmatic approach, which is the best way to diagnose PFO. And we gave the indication that based on the facilities and the skills of the centers, they should use what they can use better. So for example, if they are very skilled in transcranial Doppler, do it. Wonderful. If they have good cardiologists, do a transthoracic Doppler. But if they are still adept, use on top of the transesophageal echogram, because the cardiologist, they have to put the hand. It's not about us, neurologists. At the end, the cardiologists want this examination because they have to see how to put and how to use the implantable. So in the end, this will be the tool that make everything more definite. Regarding treatment, we gave a clear indication that patient between 18 and 16 needs to be closed. So if there is a PFO and a stroke, patient need to be closed. We also used, because based on a patient individual analysis, we used the PASCAL score, which is a morphological score on top of a clinical score. So when there's a high suspicion of a PFO related stroke, and the PASCAL shows you that it's possible or probable, then you have to close the PFO. There are also some cases where you can think when you don't have such a strong relationship, but when there was a clinical event like a long distance flight. For example, patient had a stroke after a long distance flight, and you find a PFO with not all the characteristics of the PASCAL, but there is a clear temporal relationship, then you should think about to close it. Regarding the long-term management, one of the complications that we have after PFO closure is AF. And often we do not really need how we can interpret these AF episodes, and we do not know how much they are related to the stroke. So sometimes now we have more and more evidence that putting a halter or positioning positioning a loop recorder after PFO closure does not really add any diagnostic value. So even if there's a short atrial fibrillation after closure, these patients tend not to have other episodes of AF. So what we can do, especially in the higher age, 59, 60-year-old patient, maybe there you can put it, but put it in when there is a randomized trial. And the other point is also what we saw based on our data. Higher is the PASCAL score and younger is the patient, the less we have the risk of atrial fibrillation. And another question that we asked during the guideline is how long these patients should be treated with antiplatelets. Again, small evidence, very only observational studies. So we stated as an evidence-based recommendation that double antiplatelets should be done for 1 to 6 months, followed by at least 5 years of single antiplatelet therapy. Consider that this guidelines was done by me as a chair, but my co-chair was Christian Cristipino, a cardiologist. Inside our group, we had another cardiologist, so who was one of the main authors of one of the main randomized trials. So it's very important, and we always making fun about us that they say that cardiologists always want to close the PFO and neurologists never want. So this is why we're trying to find a good agreement. And I think we found it because we looked very deeply to the morphology of the PFO. Adding this as an additional argument for closure. So we had very hot discussion in our group, and I think this is a good way to put guidance scientifically, but extremely in a very pragmatic way.